So good morning. We are back in session number 13, and whilst other sessions are somewhat centered around one topic, I'm pleased that this topic's covered actually a fairly broad range of diverse topics, and I really look forward to that. But maybe as a first starter of this, I would say dense pack session is Professor Xavier Fernàndez Busquets, who will talk about nanocarriers to treat malaria. So the floor is yours.
Okay, thank you, Cristianne, for your introduction. I always start lately my talks with this slide and this image. This is a distorted map of the world where countries are not represented by surface, but by the number of malaria-related deaths. And as you can see, this blob here is Africa. Because it's well known that the main problem that we have with malaria is in tropical countries and particularly in Africa. However, this map might change in the near future, mainly because of the climatic change, the recovery of wetlands, and also because of the displacement of populations. And it might well be that in a few years, we have an image like that, where malaria is again transmitted on the European mainland. And this might be a health problem also for Europe, because we Europeans are not so resistant to malaria as Africans are. And then if we have malaria transmission, that would be a real problem for our health systems. However, the problem that we have today is in Africa. And unfortunately, we have to be aware of the economic situation of African countries, and probably that's the reason why we don't see a lot of nanomedicines that are being developed against malaria. In the best cases, we have from time to time some new drug like artemisinin that it's discovered, and then we can afford treating people with this new drug, but we are still far away from seeing the type of nanotechnological devices that we are developing against cancer or Alzheimer being applied to malaria. So we must make do with this situation. There is a clear wealth distribution inequality. But then from the point of view of research, what we can do is to plan for newer strategies so that we can apply nanomedicine to malaria. And this is a little bit the objective of the talk that I will be presenting today. Just before starting, a quick review of the life cycle of malaria parasites. If we start with the bite of an infected mosquito, the malaria parasite from the genus Plasmodium goes quickly to the liver, where it develops during a dormant stage that can last from days to even years in some species. Eventually, when the parasite has matured inside a few hepatocytes, it breaks loose into the blood circulation where it infects red blood cells. I have to say that all the symptoms that we humans feel related to malaria come from these blood stages. And then logically, I think all the drugs that we have against malaria today are against the infection of red blood cells by Plasmodium parasites. Eventually, some of these infected erythrocytes develop into gametocytes that are in the peripheric blood circulation, ready to be taken by a second biting mosquito. Then in the mosquito midgut takes place the sexual development of the parasite, where gametocytes develop into gametes, and a zygote is formed after fertilization, which develops into an ookinete that crosses the midgut epithelium and forms an oocyst, where during about 2 weeks, new sporozoites develop that migrate to the salivary glands to be injected in the mosquito's next bite. Then, as I said, because most drugs are developed against the human, it is quite expensive to bring a new antimalarial compound into the market, essentially because we have to go through many years of clinical trials. And if this, in addition, is a nanomedicine, this makes things more complicated because nanomedicines are usually more expensive than just a simple drug. Then a number of strategies are being developed in several laboratories. In our case, we are thinking of developing strategies for targeted drug delivery to the mosquito stages of the malaria parasite. If we have a look at numbers, in an infected human, we can have up to 10 to the 11th infected red blood cells. That's one of the reasons why it's so complicated to treat malaria in an infected human. Numbers are lower if we look at the mosquito stages. Of course, as you can imagine, the problem here is that although in some stages of the parasite in the mosquito, we have very few cells, like a handful of oocysts, we have several millions of mosquitoes in any African area to treat. So that will be another problem. But we will focus here on the nanotechnology part of this new approach. Then, if we want to target drugs to the mosquito, we will obviously need new nanovectors, different from those that we have been using for human blood stages, and also new drugs with radically new mechanisms. With this aim, we are now starting the last year of an European project, Nanophiles, where the objective was precisely that, to develop targeted medicines for malaria-infected mosquitoes. The idea is to take several different nanocarrier structures, load them with some known antimalarial agents, test them first in vitro, and then finally testing them on living mosquitoes. And then I will explain a little bit the last results along this project. We started as nanocarriers using polyamidamine nanoparticles because we had been using them successfully on blood stages. These polyamidamines, we checked several different types of polymers. They form nice homogeneous nanoparticles that could be loaded with antimalarial drugs. And on blood stages, they work quite well in vitro and even in some in vivo assays with mice, because for reasons that we still don't completely understand, some of these nanoparticles, they had specific targeting towards red blood cells infected by Plasmodium. This is about a dozen red blood cells. Those are not infected, and there is only one that is infected, which is the one that got the nanoparticles. And when we loaded them with drugs, this works quite well. Then with these good results, we decided to test polyamidamines as the first type of nanoparticle to administer to mosquitoes. And then we fed mosquitoes with a sugar meal where we included some polyamidamines labeled with fluorescein to see where they were going inside the mosquito. This wants to be the scheme of a mosquito with the midgut and all the different stages that we have seen before. And then, interestingly, some of those polyamidamines, they made their way to salivary glands in the mosquito. This is the head, this is the thorax of a living mosquito. And then we could see that the fluorescence, after feeding the mosquito with a few days with this polyamidamine, this fluorescence was located in the salivary glands, which is actually good news. So we have some structures that could probably target antimalarial drugs to sporozoites. Then another interesting target is the ookinete, which is the fertilized zygote, which becomes motile and has to traverse the mosquito midgut epithelium to form the oocyst. Then we had some experiments done where we could show that heparin, this well-known and not very expensive polysaccharide, is targeting ookinetes. One reason for that might be that the receptor that the ookinete recognizes in the mosquito midgut epithelium is a glycosaminoglycan. And then another glycosaminoglycan like heparin could probably target okinates as it did. So this was good news. And then also still using some polyamidamines, an interesting target if you want to block the development of the parasite in the mosquito is bringing drugs into the epithelial cells of the midgut, because the okinate, when it traverses this epithelial layer, it goes through the cell. It's a transcellular path, so it must enter the cell. Then if we could find some nanocarrier for delivering drugs to the endothelial cells, that would be also good. And indeed, when we tested this polyamidamine, feeding it to mosquitoes, and then we detected that with an antibody that we raised against this polyamidamine ISA23, you can see here that this polymer goes inside the endothelial cells of the midgut, which is, again, very good news. Then we moved
can I ask you to wrap it up, please?
Okay. We moved then finally to assays with living mosquitoes, where we used heparin. In this case, we took blood from an infected mouse, infected with Plasmodium parasite of murine malaria. We added heparin to this blood and gave this blood to mosquitoes. And then, as you can see here, compared to the controls, mosquitoes that were fed with blood containing heparin had less infected animals. We had less infected mosquitoes. And in the infected mosquitoes, the number of oocysts was largely decreased. And this was even more dramatic if we use hypersulfated heparin. And here just an image of a midgut, a control with lots of oocysts. And we treated, when you treat the mosquito with heparin, you can hardly find any oocysts in the best cases. And then this is the last slide. We are now trying to develop single chain polymer nanoparticles for okinate targeting, where, as you know, these nanoparticles are quite versatile. You can have them water soluble, you can add them some targeting elements, and you can add also drugs to them after forming nanoparticles. And the preliminary result with 3 of those single chain nanoparticles show us that they have targeting to okinates. This is a control. In green, you can see green fluorescent expressing okinates. And with these different nanoparticles labeled with Texas red, you can see that we have an okinate targeting of around 20%. The idea now is to add heparin to improve targeting and to load these nanoparticles with some antimalarial drugs. And here are the acknowledgements, and thank you very much for your attention.
Thank you, Xavier. I'm taking a look. There are no questions from any other parties. And I must say that due to the time, it's probably better to go to the next speaker. But thanks very much for this exciting lecture on malaria and how to treat it with nanocarriers.
Thank you.
Next talk will be by Stefan Schulz about using artificial intelligence. So Stefan, please go ahead.
Yeah, thank you for the introduction. And this will be a very short overview of what AI, or I abbreviate, or everybody abbreviates artificial intelligence, is today, with some spotlights on current trends in biomedicine. And AI is one of the really oldest disciplines in computer science, and what we understand by AI today is quite different from the 50s and the 60s, where scholars and science fiction authors were enticed by what they call the strong AI hypothesis, namely on whether machines would eventually have minds and consciousness. But what AI is mainly centered on nowadays is solving problems by mimicking intelligent behavior. And this includes a broad range of AI subdisciplines like those here. But nevertheless, over-enthusiasm regarding the achievability of promises, of AI promises, led to phases of disillusion where funding agencies withdrew and activity stalled, the so-called AI winters, so in the 60s and the 80s. And nevertheless, those periods were crucial for technologies that characterize today's AI boom, such as neural networks, robotics, decision support systems, machine learning, and knowledge representation. And in the meanwhile, mainly during the last 10 years, industry has transformed AI into a really promising business. Just to mention Deep Blue and Watson and all the gimmicks with AI insights, such as translators, navigators, speech interfaces, and so on. So, and this is obviously due to very important things like the internet, the big data revolution, and especially in the recent couple of years, deep neural networks. But all this wouldn't have been possible without the tremendous increase in IT performance. There's still a lot to come, just to mention quantum computing. Well, I am now presenting 4 examples of state-of-the-art AI, and they use basic AI paradigms, namely symbolic knowledge representation and machine learning. And by the way, machine learning has now become the leading AI paradigm, even a kind of synonym of AI. Also, AI is much more than machine learning. So that you can really state that most current AI equals machine learning using deep neural networks powered by big data. The first example I choose is on image analysis, which exemplifies deep learning and also shows how the standard methodology of training machine learning systems looks like. And in this case, you see an image with nanoparticles in which experts highlighted them with green contours. And after that laborious work, once there are enough annotations, the neural network is trained. The new thing which deep learning models, opposed to machine learning, which started 30 years ago, even earlier, is that annotators don't need to predefine features like, for instance, image textures, contours, colors, and so on. They just have to mark what they consider relevant, and the rest is done by the network. Of course, there's some fine-tuning needed, but this is not done on image features, but on model features. It's called hyperparameter tuning. And at the end, with the test set, the model performs, the performance of the model is tested. And then, of course, it's decided whether it's good enough to be used in routine. Well, in this example, the contours predicted by the models are red. What the annotators had marked is green, so there is a good coincidence. And, well, then you can use it for new images, but the crucial thing and the crucial limitation is that these images need to be of the same type of the training data. The next example I give is about the field of predictive analytics. This is how machine learning systems learn to predict future events, like in this case, the risk of delirium in hospitalized patients. Here we used routine data from thousands of patients as a ground truth, trained a model, and this model was then positively validated and is now really being used in clinical routine. Every new patient is assigned to one of 3 risk classes. For instance, this is a high-risk patient. And what's quite important here is that the decisions are explained to the user. For instance, here it highlights that the patient suffers from liver problems and abnormal liver lab values, which explains the high risk. Well, this is currently running in some of our hospitals in Graz, Austria, but there are limitations. Historical data may miss changes in patient management or new drugs or tests, and this means that such predictions are very conservative. And the quality of prediction also depends from the way how data are recorded and structured, which is different in every place and which makes portability very problematic. And finally, the data that can be directly fed into such systems is often scarce, because most data are unstructured text, and structured data are often just recorded for reimbursement and also are biased, therefore. So this brings us to the third example, highlighting the technique of NLP, natural language processing, for information extraction, just to close the gap between structured and unstructured data. The concrete task here was to automatically identify key pieces of information in ophthalmology notes and map them into an information template using SNOMED-CT, international terminology, for further analysis. Clinical NLP addresses subtasks like identifying paragraphs, sentences, words, multi-word terms, and so on, and also has to deal with lexical ambiguity, with negation, with problems such as to understand that RA means here rechtes Auge, right A, and not anything else. NLP systems have typically been implemented as so-called pipelines, but increasingly end-to-end approaches are also used, like the first one, on images. You can do very similar things on text also. For instance, we are working on the detection of the smoker status based on clinical notes. And our approach is really similar to the first example. Instead of annotating contours and images, we annotate clinical text with labels such as current smoker or ex-smoker, and feed labels plus text into a deep learning framework. Well, there are many limitations of clinical NLP. Clinical language is very compact and idiosyncratic. There's a lack of resources, particularly for all languages other than English, because now what we really urgently need are expert annotated clinical corpora and localized versions of international standards like the SNOMED-CT ontology, especially with a good coverage of clinical jargon. And SNOMED-CT brings us to the last example. And this topic would be really worth a separate talk, for instance, about a large German language clinical term collection I'm building currently and thinking to SNOMED. But here I'm going to show an example from your area, namely the Nanoparticle Ontology. So don't be surprised, ontologies and knowledge representation belongs to AI just as neural networks and machine learning. The purpose of ontologies is to represent, to order, and to define all things that matter in a domain using formal logic. Here in NPO, for instance, the axiom that every nanoparticle has at least one code, at least one core, and at least one shell. I hope you agree on that. But it's not my area, but so I have to believe that. Well, ontologies standardize meaning, which facilitates documentation and communication. Ontologies also foster interoperability between different domains and different languages. And finally, formal reasoning supports use cases such as semantic search or clinical decision support. Again, there are limitations such as that users and communities agree on upper level distinctions. For instance, what's an event, what's a role, what's the difference between being part and being located. By the way, a good example where this is really taken seriously is this here. Well, perhaps, yeah, that's a reference to the previous talk. The malaria ontology is very explicit in this sense. Yeah, but also the acceptability of ontologies is limited because of the additional effort of recording clinical or research data using ontologies, that this does not immediately pay off. Well, and letting machines do the task, for instance, using NLP, does not yet yield the quality we would like to expect. So let me finish with some take-home messages. Well, impressive progress in neural machine learning, more and more undisputed, especially for images and biosignals. Good training data are expensive, clinical data often unavailable. Structured clinical routine data is often too biased and too limited in scope. There's still a long way towards real machine understanding of clinical language. There's a need for explainable AI, but we have shown that this works. Yeah. A lot of maintenance and training effort is required for standards like ontologies. Making data shareable, explicit, and interoperable does not come for free. And it's an important field, but there was no time to address this. Ethical issues in AI definitely also deserve attention. So thank you very much.
Thanks, Stefan. A truly fascinating story, which is probably indeed way too short, presented in this 10 minutes only. There are no questions from the audience. I do have a more, let's say, futuristic question. If we would have CLINAM 2025 where would the field then be? Can you elaborate briefly on that?
Yeah, well, I think that especially image and biodata application for machine learning will be much more widespread. This is probably a relatively realistic prediction. Everything which includes the clinicians, clinical routines, documentation standards, I am less optimistic, because on a very short-sighted view, well, clinicians, they are always under stress, and if they have to make more effort in good clinical documentation, for instance, using ontology, probably they won't do it, or they will find excuses. But nevertheless, I think that, and I'm working in this field, that there will be progress in natural language processing. There have been a lot of progress. Look at, for instance, Google Translate, how it worked 10 years ago, how it works now. But you need clinical data to train. And this also in 5 years from now will not be easy.
Okay, thanks again, Stefan, for your talk. Really impressive. So then we actually stay in grass, but go to a completely different topic, namely focus on the role of B cells in atherosclerosis, presented by Harald Menge, if I speak out correctly.
Hello, ladies and gentlemen. Do you hear me? Okay, I will now give you a short overview about B cells in atherosclerotic disease. As you all know, vulnerable atherosclerotic plaques are very important because they are carpet lesions. They are responsible for clinical endpoints like myocardial infarction and stroke. And these vulnerable plaque lesions are characterized by excess of inflammation with involvement of monocytes, macrophages, immune activation, and pro-inflammatory cytokines. And a better understanding of this process here will help in management of the patients and also help to avoid clinical endpoints like myocardial infarction and stroke. The offender number one, well established now, is the monocyte and the macrophage. They are involved in a complex way because there's the balance between M1 and M2 macrophages, and this polarization of macrophages is much more complex with many other systems components involved, the grade of allyl oxidation, and also paraoxonase and all the dyslipidemia plays an important role. Many research has been spent on this, but unfortunately, a therapeutic modification of macrophages in clinical routine does not exist, and there is no clinical relevance for this. The next offender are T cells. They are involved indeed in the inflammatory perpetuation in atherosclerosis. In this context, the critical amplification of the inflammatory response and of the T cell activation in draining lymph nodes and spleen plays a very important role. And as you can see at the example of T cells, it is some way more important what happens outside the plaque in draining lymph nodes and spleen. And so also T cell polarization was discussed in animal models. Many data, according to this, show again a quite complex network, but the problem remains that a great part of the available results originates from mouse models, and there is no relevance for the human system. So the question arises how we can achieve a better understanding of the immune mediated inflammation to act effective in clinical routines. And so In the last time, B cells came into discussion, and they turned out to be very important, possibly more important than macrophages and T cells. Why is this so? Because it is can mainly be explained by the fact that B cells produce anti-inflammatory, anti-enteroprotective immunoglobulins. The immunoglobulins belong mainly to the IgM subtype, isotype, if they act enteroprotective. And as you can see here, they act against oxidative epitopes, for instance, represented by OXLDL. They decrease the macrophage activation, they increase macrophage apoptosis, and they increase also the production of IL-10. The other Ig immunoglobulin subtypes, isotypes, are also produced by B2 cells, as shown here, and they act more pro-atherogenic. And so there is also again a balance in the B cells between pro-atherogenic and atheroprotective subtypes, whereas the B1 subtypes is atheroprotective. And from patients with autoimmune disease, new data come now because these patients suffer from an increased cardiovascular risk, and they already receive now B-cell depleting modifying drugs, and they allow us to come more into that with the knowledge about the role of B cells in atherosclerosis, and they are promising data that B1 cells are very important for the atherosclerotic stabilization process. This slide shows you that not only in the plaque, but also in the perivascular adipose tissue and in adventitial tertiary lymphoid organs, like draining lymph nodes of the aorta, happen very important things which control the T cell function by B cell subsets and production of IgM, which acts as a brake for the atherosclerotic perpetuation in culprit lesions. Again, the bone marrow and the spleen is important in this context. You may argue now that this data coming from animal experiments, from mouse experiments. This is true in many cases, but new experience shows that also in the human system, B1 cells play a very important role comparable to the murine models from which this data come in the great amount. The B1 secretor cells in the human system produce atheroprotective IgM, and the B1 orchestrator cells control the T cell activation. And so we can conclude that B cells in atherosclerosis play, for instance, I think a most important role. New evidence exists that B lymphocytes can also influence the clinical course of atherosclerosis. And so I think in the focus of intense research in the next years will the human B1 lymphocytes and also nanotechnology are important in this context, because by nanotechnology, the function of B1 lymphocytes can be influenced, they can be stimulated. The traffic to and localization of B1 cells in vulnerable plaques in humans may give answers to the old questions how immunoglobulins and act in the vascular atherosclerotic lesions. And so the following questions remain: do immunoglobulins like protective anti-LDL, OXLDL, IgM enter from the luminal side or from the adventitious vascular surround the plaque? Do non-stenotic vulnerable plaques, which are very often responsible for clinical endpoints and cannot recognize as far as possible, you must recognize to prevent clinical endpoints, can they show a lower number of protected B1 cells? what happens in lymph nodes responsible for the dark region, like draining lymph nodes of the aorta and so on, will it make sense to administer protective immunoglobulins therapeutically in atherosclerosis? Nanoparticles can be used to transport such protective immunoglobulins together with IL-10 into activated atherosclerotic lesions. And does it make sense after invent, before invent, or at both times, time points to administer protective immunoglobulins? These are still very important open questions. To what extent can findings be transferred to a new, better therapy of human cardiovascular disease by better understanding of this B cell subset balance, which is central of the B1 cell. So, to be concluded, inborn and adaptive immune mechanisms contribute essentially to atherosclerosis. The role of B cells in immunoglobulins gains on importance. Nevertheless, many attempts of anti-inflammatory and immunomodulatory therapy failed so far. This may be caused by individually different complex pathologic networks, which may explain this deficit. Not at least high cost of immune therapies are responsive for the fast rate situation, and better animal models with stronger human relevance, and also by use of nano medical methods, will now pave the way for a more successful personalized anti-inflammatory management of cardiovascular disease, and the B cells and the protective immune globulin production by them will play a central role. Thank you very much for your attention.
Thank you, Harold, for shedding some light on the role of B cells in atherosclerosis. I don't see any questions from the audience coming in. I did have one question myself, namely, you indicate you could use nanoparticles to bring the immunoglobulins and even maybe some other potentiators like the IL compounds you talked about, but clearly that's quite a, let's say, difficult composition. So aren't there any small molecules that you could envision by entrapping in them in the nanoparticles that thereby you would have an added value, or is that probably some line of investigations ongoing?
I think that liposomes can be used for this. Liposomes are, if they are applicated in the right way, tolerable in clinical patients, and these liposomes can be attached with IL-10 and loaded also with protective IgM, and so this may be an opportunity, or it must be sought or developed that the B1, the balance between B1 and B2 cells can be influenced by mediators which can be transported in a targeted way to the vulnerable atherosclerotic lesions. And I think in this context, nanoparticles and most of all liposomes can be useful.
Right, thanks. There is still one question, so maybe if you could give a brief answer. The question from Donald Bruce: which animals are suggested?
Animals, we have to improve the mouse models, I think, to better understand the human situation. And after this, I think in more human-like systems, pigs can be used for examining these approaches, but the problem is that they are very difficult to handle, and the experiments are very expensive with these pigs, for instance. And as the last step, primates will be a way to check this.
Okay, Thanks, Anne. And with that, I think we have to go to the next speaker, which is going to be Robert Gersma from the Netherlands, and he will talk about risk management for nanomedicinal products.
Thank you. I think the previous speaker has to stop sharing. Can I just overshare? Okay, thank you, Cristianne. Good morning, everybody. I'm going to talk about risk management for nanomedical products. To start with, nanomedical products, what are we talking about? For me, quite simple. In Europe, we distinguish two kinds of medical products, medicinal products and medical devices. And when they are enabled by nanotechnology, I call them nanomedical products. So either nanomedicinal or nanomedical devices. And just to look into the definitions, I won't read them out for you entirely, but medicinal products are aimed to treat or prevent disease, and they are restoring, correcting, and modifying physiological functions by exerting a pharmacological, immunological, or metabolic action. If you look at the definition for medical device, it also has medical purposes, several identified, and then it says which does not achieve its principal intended action by pharmacological, immunological, or metabolic means. So if you look at the question, are we dealing with a medicinal product or a medical device? In theory, it's pretty clear. You look at the mechanism of action, it's either pharmacological, immunological, metabolic, or not. But in practice, that's not so clear if you want to look into that. The consequence is that the regulatory pathways differ, and that creates a challenge. And I'd like to go into that, but unfortunately there's no time for that. In the European project Refine, this is one of the challenges we identified. You see the website on the right hand corner. Take a look at the website. We also will have a conference next week that you can join, and we look at this challenge, but also other challenges. The good news is that for risk management, there are no fundamental differences when you have a medicinal product or a medical devices. If you look at the regulation again, they also ask for the same things. Medicinal products, they say you have to look at the risk-benefit balance, and you have to have a risk management system in which you prevent or minimize the risk. And in the medical devices, it says you have to look at acceptable risks when weighed against the benefits, and you have to reduce risk as far as possible without adversely affecting the benefit-risk ratio. And also here, you must have a risk management system. So far, so good. Also, the regulatory systems are well aligned. Of course, risk management is a complicated process, which is not entirely spelled out in the regulations. But there's regulatory guidance. For medicinal products, there is a guideline, ICH Q9, on quality risk management. And in ISO 14971, the application of risk management to medical devices is explained. And also here, if you look at both documents, the same principles are applied. So in view of the time, I will now mostly go to the medical devices part. There are some regulatory changes going on. I thought it would be good to briefly point out what's relevant for nano. First of all, there is a transition from a previous, or I must say current regulatory framework to a new one. The transition period was supposed to stop in May 2020. However, due to COVID-19, a lot of implementation actions by all stakeholders were no longer possible to be carried out in time. So it was a 1-year delay. The transition period is now until May 21. But with regard to nano, the older directives had no specific provisions for nanomaterials. The new medical device regulations, however, do contain provisions for nanomaterials. And what kind of provisions are these? There is a definition for nanomaterial. which I won't go into either, because that could take another 10 minutes talk. And it says in the general safety and performance requirements now specifically that special attention shall be given to nanomaterials. So how can you do that? Risk assessment of nanomaterials used in invasive medical devices. The principles for this have been discussed and presented in a scientific opinion of the SCANIR committee, Scientific Committee for Emerging and Newly Identified Health Risks. You can see the link below. And basically the conclusion was that the basis for the risk assessment of nanomedical devices is the same as for other devices. Just you have to take these specific characteristics into account. And that's in particular, you have to do a detailed physical chemical characterization. You have to do specific toxicokinetic studies in case there is a potential release of your nanomaterials from the device. And you have to look at certain pitfalls in toxicity testing. Due to the sampling, there can be interference with the methods, to look at the mechanism. So there is a number of aspects to look at. If you look at toxicology, this is, there are standards for that as well. The 10993 series for biological evaluation of medical devices is a framework that spells out how to do this for medical devices in general. And there is a specific guidance document on how to do this for nanomaterials as part 22. A conclusion that was important was indeed the nano-related risk was primarily related to release of nanomaterial. Also, nanomaterials that stay put on the, like a coating will have effect, but the main risk will be related to released nanoparticles. An important regulatory change, which I will briefly mention, is that there's also a new classification rule. It is classified in a higher risk class, which means that there will be more scrutiny to get market authorization. And the key aspect is that you have to look at the potential for internal exposure. If this is high, you are in the highest risk class. And if you have a negligible potential, you are in class 2A. The main issue related to 19 that need guidance have been identified as, first of all, how to interpret certain aspects of the definition. When do you actually have a nanomaterial? Furthermore, what is actually internal exposure? And thirdly, when is the internal exposure high, and when is it medium, low, or negligible? This is still a work in progress. The guidance is being developed at the moment, and it turns out that these are quite complex issues. Fortunately, in the MDR, there's a recital linking to the scientific opinions for 2 of the issues, but for the third one, the Joint Research Center of the European Commission was good enough to provide a complete report with an overview of concepts and terms used in the definition of nanomaterial. So the issues related to interpretation of the definition for nanomaterial in the medical device regulation, which is basically the same as the general one, can be found there. The other 2 aspects, potential internal and external exposure, you can look at the same opinion from the scientific committee, and there these concepts are being used, and there is a table with an estimation of the internal exposure, and it's expressed in high, medium, low. So here you can get a starting point on how to do your classification as well. So it's in the opinion it's given as a starting point for the risk evaluation, but this can also be used to do the risk classification. In the opinion, there's also a nice flowchart of how to do the actual risk assessment related to nanomaterials as a phased approach. It's a basic, similar to other types of toxicological risk assessment, where you look at exposure assessment, and you then take into account particle distribution and persistence. Also, you have to look at the toxicological evaluation and do your final risk assessment. There's an elaborate explanation about this in the opinion. If you are not familiar with it, I would recommend to take a look. To conclude this talk, I would say that indeed medicinal products and medical devices are in certain respects different, but in also other respects they are not so different. And in the end, we need to consider the benefit for the patient that will be treated with the medicinal product or the medical device. And the benefit should outweigh the risk, obviously. Thank you for your attention.
Thanks, Robert, for this talk, which is somewhat probably getting a little bit lesser of attention, whilst clearly important for the clinical translation. And in fact, I see there is no question for the public, but rather my question is, when should you get these topics involved? Meaning as of the early, let's say, invention, that's probably too early, but probably if you are embarking on clinical trials, then it's too late. So where would you advise to have these regulatory elements come into the overall development plan?
Thank you. Yes, that's a very good question. I would almost say you can't do it early enough. Even shortly after you have had your first idea of the new product, when you start further developing it, it's good to consider which kind of risk assessment you can do. And if it turns out that you are using a highly toxicological particle, then you may want to stop straight away and try to find another particle to further develop your invention. Because the earlier you are in your development process, the easier it will be to change that. And also, if you talk to the regulators about this, they will become familiar with your product. So in the later stages, you will have an easier task to get to start your clinical study or to go further to registration, I think.
Yeah. Well, thanks, Robert, for that. Thank you again. Let's move on to the next speaker, which is actually, I would say, a practical experience of what you just discussed, namely Laszlo Desi, if I speak out correctly, will talk about safety testing of iron oxide containing nanoparticles for later clinical use. And it's a nice bridge with the previous speaker. Laszlo, the floor is yours.
Thank you very much. Good morning for everyone. So I'm going to talk to you about the effects of dextran coating nanoparticles and iron oxide containing nanoparticles, which is a collaboration of Semmelweis University and SEON of the University Hospital of Erlangen. Oops, I don't know what's going on. All right. Okay. The super-paramagnetic iron oxide containing nanoparticles, spions, has been used in the past decades for cancer prevention, diagnosis, and treatment. And it contains an iron oxide core, and it's covered with various substances, for example, dextran and maybe ligands bound to the surface. And these iron oxide containing nanoparticles are used to magnetic resonance imaging, of course. And also, if you consider the past few years developments, then you could see that a few years ago, there were on the market ferromoxides, ferrocarbotran, ferromoxtran, Cineram, and Resovist, and these compounds. And also Resovist was not long ago approved as a new clinical contrast agent, and also Ferrahem has been used as a iron substitute for chronically ill kidney patients. However, there has been some problems emerging, namely hypersensitivity reactions were found in the patients after they were marketed, of course. This is reviewed in this article by Professor Sebeny and collaborators. And as a consequence, Rienzo has been recalled, and also ferromoxitol, ferrohem, and also Cinerem and Rezovist has been recalled. So it's really a big problem of this hypersensitivity reaction. So therefore, we investigated this phenomenon. First of all, the nanoparticles had a benefit because the classical side effects disappeared due to passive and active targeting. However, new side effects revealed, like this so-called hand-foot syndrome, and this has been mentioned in the morning as hand-foot syndrome of the patients, but in fact, this hand-foot syndrome is the list of its problem. We call these reactions CARPA. Why? Because it represents a complement activation related pseudo-allergic reactions. This is an infusion reaction. Then when nanoparticles are given in infusion, then it manifests in an anaphylactic reaction. The reason is that the size of these nanoparticles are very similar to viruses, and therefore they activate the immune system, namely the complement system and other reactions, and that makes this. And the major systems of this CARPA, both in humans and in animals, are hemodynamic, cardiopulmonary, skin and blood cell reactions, and these are very, very similar. And the mechanism of the CARPA is quite complex. We understand, but still there are some parts to be explored. So first, the reactogenic nanoparticles, when infused intravenously, cause a complement activation, and there are the release of primary mediators and also anaphylatoxins like C3A and C5A, and also there is a reaction on the cells in the blood, mast cells, basophils, leukocytes, and there is the release of secondary mediators, for example, platelet activating factors, histamine, or thromboxane A2, which is a strong vasoconstrictor. So therefore, we call this double hit hypostasis. And unfortunately, these reactions are present in the case of many substances, not only for liposomes or other nanomedicines or spions, and in a relatively high frequency, and sometimes there are death cases. So therefore, the regulatory response came from the FDA and also EMA, and there was an update on EMA's immunotoxicity regulation, and they said that animal models should be considered to evaluate the extent of these potential adverse effects. So we have such a model. This is the porcine CARPA model. Pigs are very sensitive to this hypersensitivity reaction, so therefore they represent a good model. While the frequency we have seen in patients, it's between about 1 to 10%, but in pigs, in almost every case, they respond with these reactions. And we different parameters, but one of the most important is the pulmonary artery pressure change. And also we monitor the blood cell changes and other parameters. And also we take blood samples and the mediators, and we see the similar hemodynamic, cardiac, skin and blood abnormalities as in patients. And this skin reactions is very similar to the hand-foot reaction. So here is an example after intravenous administration of a liposome. And here you can see this is the most characteristic change in the pulmonary artery pressure, and also the flash reaction, and also an increase in thromboxane A2. We use zymosan. Zymosan is a glucan, and this can be found on the surface of fungi like yeast, and it's very important in our studies as a carpagenic agent, and it activates the complement system, but not only the complement system, but also the macrophages, and activates TNF-alpha, NF-kappa-B, TNF-alpha pathway, and causes the release of mediators. So we have tested the effects of Ferrahem and Resolvist in porcine carpa, and I'm showing you mostly the hemodynamic changes and sometimes thromboxane changes, and the blue line represents an increase in the pulmonary artery pressure. It's a transient but relatively high increase, and also in parallel we see thromboxane release, and also this is the effect of zymosan. And I forgot to mention that this is a relatively low dose, 0.5 milligram per kilogram, but also in a tenfold dose we saw similar effects. Ferrahem had even more harsh reaction, and it really gave an anaphylactic shock. What I mentioned sometimes happens also in patients, and it could be even deadly. And we saw an example here, for example, for the low dose 0.5 milligram per kilogram, and also it required resuscitation and artificial ventilation, and also administration of epinephrine. And in another example, in a high dose, it didn't give such harsh reaction, but it also increased pulmonary arterial pressure. And then we started our collaboration with SION, headed by Professor Christoph Alexiou, and our group is headed by Professor János Szebeny. And first we studied spions, what was constructed in SION, and it was coated with lauric acid and bovine or human serum albumin. They had a paper on it before, and unfortunately we found that this compound had similar hypersensitivity reactions as we have seen in Resolvist and Ferrahem, and here we sometimes saw also respiratory arrests. But when the bovine serum albumin was replaced with human serum albumin, it looked like that it was somewhat better. And when we administered only human serum albumin, we also saw such reactions. So maybe it does not cause carpa. But then we started our new collaboration first in the framework of an EU project, Nano Atero, and they constructed in SION a dextrane coating iron oxide containing nanoparticle. And you probably remember that there were problems before. So they found out a new method how to arrange dextrane and how to formulate these particles. And first, we tested an 80 nanometer particle. It was also in debate that it counts a lot, the size, not only the surface composition. And it looked like, if you just consider the blue line, that there was no carpa reaction due to 0.5 or 5 milligram per kilogram dextrane, while zymosan showed the same response. And here you can see also these bars, the thromboxane, which parallels well with this pulmonary arterial pressure reactions. So here is our joint paper on these studies. And the next one, they made several studies in Xeon to reduce the size, and they produced different sizes, and we tested the 30 nanometer size spion, and fortunately it had the same good properties, that it doesn't cause CARPA in our porcine model, which is a very sensitive one, both in 0.5 and in 5 milligram per kilogram dose. And also you can see here the thromboxane, which didn't change after injection of the spion DEX, but zymosan had a harsh reaction. And here's our joint paper on this study. And in conclusion, this study investigates the immune reactive properties of spions in a highly sensitive model of CARPA in pigs. And we have found that ferrohem and resoviscose severe hypersensitivity reactions in our porcine model of CARPA. And our studies with Xeon LEBSA spion indicated that possible rise of massive CARPA can occur with such nanoparticles. Human serum albumin might help on it. However, turning to another type of spion, the Xeon DEX spion, modifying the synthesis procedure and the surface coating, turned out to be without hypersensitivity reaction. So this implies significant advancement in this field, and the potential for safe clinical use of these nanoparticles in the future. Thank you for your attention.
Thank you, Laszlo. Interesting talk about indeed the different animal models to test this potential lethal effect, apparently. I have a question from the audience, namely from Reynaldo Digigo. What's the size limitation to avoid CARPA? Nanoparticles below 70 nanometer average size should be sufficient to avoid CARPA, with a question mark?
That's a very good question. Like I mentioned, CARPA is dependent not only on the size, so size in itself won't stop CARPA reaction. So the surface decoration, if it's a charged particle, or for example, for liposomes, the pegylation, which is often used to stabilize this compound, they are all a parameter of which determines the CARPA. We know that this size, which is the viral size, it's about that causes the CARPA, but it's not exact. We don't know exactly what to do. So therefore, you need to do not only size changes, but also surface changes, or in the synthesis some modifications, and you need to test. Our porcine model, of course, is a very sensitive one. So it doesn't mean if a particle has a reaction that in all cases there is human reaction, but it's a word of caution. So so not only the size matters.
Okay. Thank you for that further explanation here. Let us then move to the next speaker, and I think what Laszlo has particularly described is a little bit of trial and error, like learning by going forward. The next speaker, Matthias Wagner, will actually talk about quality by design of nanomedicine. Matthias, the floor is yours.
Very well. Can you hear me well, and can you all see my presentation well? That's most important here. Can you see that?
Yes, thank you.
Okay, very well. So yeah, thank you for the kind introduction. It's also a pleasure to speak here today. And quality by design is basically a way of, on the one hand, you have to know what you produce. On the other hand, it's also a question what it does in the market. And I think this is also the bridge that we built from the previous talk. And I want to also show what nanomedicines have achieved over the last years. I thought I start also with the good news for all of us. So when we are looking into nanoparticle design today, I can also say that I do not want to state the obvious, but we produce nanoparticles much better than we did 30 years ago. We have a lot of technologies which also translate to a GMP environment, for example. We know how to produce liposomes, And this is just an example, but I think many of the colleagues also have those microfluidic devices in their lab, which also are able to very accurately produce particular particle sizes and to test them later also first in animals and then maybe in humans as they go into clinical translation. However, something that we do not fully understand yet is actually the drug-carrier interaction, which dramatically changes in the physiological environment. And another thing which is very important to understand is that nanocarriers, and I'm talking mostly about those injectables that we have also been speaking about before, that they are physically defined entities, which means also when you're looking into the pharmacokinetic data, when you're looking into the first clinical data that is generated, then actually you have a physical separation problem because you have a blood sample and later you have to get out the nanocarrier. And this also is a flaw in all the data that we find. Basically, what my group is doing, we are developing in vitro tests. We try to make predictions of what happens in the in vivo situation. And this requires also to look very closely into this physical separation that we do. And this is one of the first outcomes that my lab ever produced. I think we started this project a few years back. We started with a release technology that you can also use for quality control purposes, where we just looked into what can we do to look or to use a standard assay that every regulator knows for testing liposomes in a very highly standardized manner. And if you look into the literature, you do not find a lot of the, that actually there are not many standards out there. So we developed this dialysis cell, and this really produces you very fine separations between the different particle fractions that you have. And actually release is also a kinetic process, which means many of the chemical methods that you may have in mind also drop out. So you have to really kinetically measure what happens and how much drug leaks out of your carrier. That is the purpose of this measurement that we carry out. Just to give you an idea how we also use this technology or how we can use this technology. Every nanoparticle technology separating the drug from the carrier has two specificities in, so to say. The one is basically you have to select the right size fraction, and the other one is basically that you also have to be kinetically accurate. You have to measure how much is leaking out. Actually, here in this graph, you can see the size fraction. So basically, we are able to distinguish between the liposome, the fraction of the drug which is bound to proteins, and the free drug alone, which means size-wise, we are very good in our separation in this assay. On the other hand, we are using also this dialysis-based assay, a lot of normalization and reference experiments to basically extract also the information that we are kinetically accurate, that we are measuring really how much drug over time leaks out of the carrier. When you very accurately can measure and detect also how much drug is released from a carrier, there's only one appropriate way of really showing that this means something for the in vivo situation. And this also in a regulatory sense is in vitro in vivo correlation. And this is also why we started to do a lot of modeling in this area. And basically, one of the first things that we did was to look a bit closer at the old formulations, because you can learn from the old formulations a lot about the future of nanomedicines. And what we came up with is a very smart model. We heard to talk about AI before. We do not have big data in nanomedicine. We have few patients in pharmacokinetic studies, which is small. So you need smarter models to make also the most of this data. And this is basically just a description of what happens to nanocarrier when you inject it. First, you have the infusion. Then sometimes we see a certain delay also in the distribution in the patient. So sometimes a delay in the Cmax value, or the Tmax is the name better. So basically we call that the vascular transit. Then it's completely distributed. Then you have the carrier bounded fraction, and this also is limited in its mobility, which means that it takes much less space, also much less volume than the free drug, because the free drug can diffuse into every tissue. But carrier also undergoes elimination, which means basically it can be filtrated by different organs, and then it is accumulated. It's not completely gone. And the other way of reducing this carrier bounded fraction of the drug is the drug release, and the drug later, just like the free drug always behaves, it is also eliminated and going into the periphery. This smart model we used all on many different formulations that we found on all data sets, basically. Let me show this first outcome, what kind of data we generate. And I used also a study which Doxil is the most famous nanomedicine, I would say, today. And we basically made this smart deconvolution, and what it gives you is, by calculating, basically, you get the encapsulated and the non-encapsulated fraction of the drug over time from a total concentration time profile of drug substance, which means, okay, so back in the talk, sorry for the interruption with the internet, however, so I was talking about the Pbnb model. What you see here is basically a retrospective data extraction that this model also is doing, which basically means that we make or we take data that we have in, for example, an old pharmacokinetic profile, total plasma concentration, and we extract from that also over time the information of how much is encapsulated and how much is non-encapsulated. And this kind gives you access to a lot of more data, because you basically can also use a lot of old pharmacokinetic profiles to learn more about those formulations. This here is just showing the overlay of predicted versus observed, which means basically we compare here our simulation with the bioanalytical assay that was carried out, which means basically that we are really hitting the line here and that we are able to extract this information without telling the algorithm which is encapsulated. At this point, you may say that basically this works best for Doxil because it's very stable and very nicely, a nice formulation also. However, if you also look at the next slide here, you see that we did not only do that for Doxil, we also did it for Ambisome, Myoset, Foslip, and Nanodox, all different formulations where we retrospectively extracted the information that also produced this overlap between encapsulated versus observed. What has that to do with quality by design? Everything, because when you have the information of how much is released in vivo, then you can also make a comparison between what is released in vitro and what is released in vivo. And this is the next slide showing, this is an IVIVC that we produce with our release assay for Foslip, a formulation that we have been working for a while, which basically means we are using a smart algorithm to extract the information on a quality parameter, which is the drug release. And this we use to carry out such an in vitro in vivo correlation. So finally, a quick summary of my talk. I know time is short, so basically nanoparticles and liposomes can be manufactured today. That's the first step in quality by design, producing what you want to produce. We were able to prove that we are having a biorelevant assay, which really predicts also the in vivo performance of formulations. And for that, we are using smart deconvolution techniques, which may in some cases replace bioanalytical methods, but they can also serve as a validation in the clinical practice that you just show that your bioanalytical assay is a good one. I only had 10 minutes, so I'll also put an ad into this presentation for my talk on the 18th, 2 p.m., where I talk for an hour, so there I have more time. Thank you very much.
Thank you, Matthias, for the very interesting talk about indeed the design of these nanoparticles, particularly the nice correlation that you seem to find in developing these type of models. Maybe indeed, because of the time, I unfortunately have to go forward to the next presenter, which is Cristianne from Barcelona, who will talk about novel nanosystem consisting on combined gene and immune therapies.
Okay. Thank you very much. Let me present the presentation. Now, okay, so thank you for the introduction and thank you the organization committee for giving me the opportunity to present our work, which, as I was said, is entitled Designing Novel Nanosystems Consisting on Combined Gene and Immune Therapies for Non-Small Cell Lung Cancer. Lung cancer, as you may know, is a disease which affects more than 2 million new cases every year, and the 5-year survival rates are very poor. As you can see here, lower than 20%. Non-small cell lung cancer can be divided between small cell carcinoma and non-small cell lung cancer, being this last one classified in terms in adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. And as you can see here, this is the most prevalent one. Current therapies, without distinguishing between the lung cancer types, consist on chemotherapy, radiotherapy, and surgery, but they produce severe toxic side effects and tumor resistance. This is why novel therapies are required. In this context, the use of targeted therapies which try to modulate the gene expression, for example, by using an antisense-mediated gene silencing, and immunotherapies, among them mRNA vaccination, could be an interesting alternative. Both strategies have in common the use of gene material, but taking into account the labile nature of genes, of nucleic acids, we need a carrier system. So we have a library of oligopeptide and modified PBAEs, polyvet amino esters, which can at the same time protect the nucleic acid and achieve a selective targeting to the target cells. So the objective of our work was to achieve a combination therapy based on targeted PBAE nanoparticles to design a novel standard of care for non-small cell lung cancer patients. And this objective can be designed in both monotherapies individually, the one for gene silencing and the other for tumor vaccination, and finally to establishing the basis of a combination therapy between both strategies. So which is the common point of these both monotherapies? As I have already presented you, the polyvet amino acids. PBAEs are proprietary polymers, as I said, from our group, which are synthesized by Michael addition of primary amines to acrylates to form these PBAEs that then, in a second step reaction, cationic peptides are added at the acrylate group to achieve a polymer with a highly cationic charge that, by electrostatic interaction, can form polyplexes, taking into account that nucleic acids are negatively charged. In the following slides, I will present the specific application of these PBAEs for the purpose of the talk, for the non-small cell lung cancer. Let's start by the oncogene silence. As it happens in many tumors, mTOR is an oncogene which is overexpressed in tumor cells. So encapsulating an siRNA that codifies for this mTOR gene, we can knock down, or in an ideal solution to knock out, the gene and achieve that these cells are more sensitive to further chemotherapy or to further therapies for lung cancer. The first step that we did is to test which was the appropriate PBAE siRNA ratio to achieve the complexation and protection of this siRNA. As you can see in the left part of the slide, without the presence of FBS at the right part of the figure, independently on the ratio tested, all of them encapsulated siRNA as it is seen because it cannot migrate through the gel. However, when these particles were incubated with serum conditions, simulating physiological environment, the lowest ratio cannot be used because some fraction of the gel moved, some fraction of the siRNA moved through the gel. So we selected the lowest ratio possible, 25:1, to perform a nuclease protection study. As you can see here, only when siRNA is encapsulated inside nanoparticles, it is protected from the degradation of nucleides, one of the aims of using these nanoparticles. Once decided that nanoparticles are appropriated, we physicochemically characterize them, and as you can see in this table, they have sizes below 140 nanometers. They are slightly polydispersed, highly cationic, and which is more important in here is their high encapsulation efficiency, which makes its manufacturing process scalable in an effective way. So we have demonstrated that we are able to form these nanoparticles that protect siRNA. In further in vitro studies, we confirm the compatibility of these nanoparticles first with blood cells, because we want to administer them parenterally, and as you can see here, hemolysis was not produced at all the concentrations tested. And once we tested the viability, you can see that the polymers are not toxic. If you look at the orange bars, you can see that no toxicity was produced when a non-codifying siRNA was used. On the contrary, when we use mTOR siRNA, a concentration-dependent decrease on the viability was produced. So, in fact, our particles are demonstrated to be effective at killing tumor cells. Why this killing was produced? We demonstrated that it was because of mTOR silencing. As you can see here, the results of a Western blot analysis, only when mTOR siRNA was codified, the gene was silenced. Finally, we performed an in vivo efficacy study in which you can see that we were able to reduce the tumor size, the tumor growing, when we treat the animals with the nanoparticles as compared with the tumor growth of a control group. So we have the first proof of concept that these nanoparticles could be appropriate for the oncogene therapy. Let's continue by the other monotherapy, the tumor vaccination. The same nanoparticles were used, but in this case, what was encapsulated was mRNA. mRNA codifying for tumor-associated antigens to enable the immune system reawaken and attack these tumor cells. As you can see here, the particles obtained are slightly bigger because the mRNA is bigger, so this is an expected result. They maintain their slightly polydispersed and they positive surface charge and high encapsulation efficiency. When we perform in vitro proof of concept studies using a reporter gene, as you can see here, our particles were highly efficient transfecting antigen-presenting cells, and among them, professional-presenting cells, which are dendritic cells. This is a key result, since transfecting this kind of cells in vitro is usually very difficult. So we have an efficient methodology to selectively transfect these cells. Then we went to in vivo studies. After parenteral administration, after intravenous administration, you can see that particles are exclusively accumulated in the spleen. And among the cells in the spleen, they are again accumulated and transfect dendritic cells or in general antigen-presenting cells of the spleen. So yes, we confirm that our nanoparticles could be appropriate for vaccination purposes. In fact, in here, I have only shown you the results for therapeutic vaccination against lung cancer, but I wanted to add that we are also developing this methodology to engineer a preventive vaccine against COVID-19 infections. So finally, I would like to conclude that I hope that I have convinced you that we have a very versatile library polymer that can be used for many anti-tumor applications. We have demonstrated already that the efficacy of nanoparticles in silencing model oncogene and as well as potent and cancer vaccines. And we need to further perform for the possible use of both monotherapies. Last but not least, I would like to acknowledge the team that has participated in this work, specifically Professor Burros, Dr. Guerra Rebollo, Laura Olmo, and Coral Garcia Fernandez, who performed the experiments, the funding received, and thank you for your attention.
Thank you, Cristianne, for a very, let's say, condensed talk about this highly potential platform using or showing examples of 2 different applications already. I do not see any questions from the audience. My question is, do you envision to literally also combine the things? So both mRNA as well as siRNA in one single nanoparticle, or would you rather see different applications?
I don't know if I have understood correctly the question, but the idea is to have both nanoparticles separately because they will not be administered at the same time to the patients or first to the animal models, because we need first, we think that the most appropriate schedule would be to first sensitize the tumor cells using the oncogene strategy, and then to perform the vaccination to achieve that this let's say sensitized tumor can be detected by the awakened dendritic cells.
Thanks for elaborating on that. Then, because of the time, let's move forward to the next speaker. Thanks, Cristianne, for this.
Thank you very much.
The next presentation is by Francois Lux, talking about translation to the clinic of an ultra-small gadolinium-based nanoparticle.
So, thank you. I hope you see the presentation. Okay. So, thank you for the kind introduction. Today we'll speak of the translation to the clinic of an ultra-small gadolinium-based particle. It's a radiosensitizer and also an MRI contrast agent. So I will first present rapidly the particle. It's composed of polysiloxane and DOTAGA gadolinium. It's relatively small, 3 nanometers, to have a good renal elimination. And it has also some reactivity properties that are twice to 3 higher than the DOTAREM that is a gold standard in MRI. First, we have performed some experiments on animal models. So the idea here is to have a gliosarcoma-bearing rat, so it's a brain tumor cancer. And as you can see, before the injection, there is no highlight of the tumor. And 1 minute after the injection, we can see that there is an increase of the contrast in the tumor. And then we have a maximum at about 10 minutes after the injection. So what we do then is to perform radiotherapy, because the idea of the particle is to enhance the effect of the radiotherapy. And as you can see here, all the rats are dying close to 20 days after the implantation of the tumors. When we perform the radiotherapy in blue, there is a clear increase of the survival of the rats, and there is an higher effect when we perform the radiotherapy in combination with the particles. It's a red curve. So for the moment, we have performed preclinical proof of concept on about 12 different kinds of cancer in rodent models. And so then we go to the clinic in 2016 to test this concept on humans. The idea of the protocol, it was a phase 1b protocol on 15 patients, and it was to treat brain metastases with whole brain radiation therapy in combination with the particles. So here you have the protocol. It was performed in Grenoble, and the idea is to perform 10 fractions of radiotherapy of 3 gray each, and to inject the particle before the first radiotherapy station. Here you have a description of the different patients. As you can see, there is 4 different cancer types. It's lung cancer, melanoma, colon carcinoma, and breast cancer. And we treat only in these trials metastasis issued from these primary cancers. For the brain metastasis, there is a large number of brain metastases from 4 to more than 50. And I forget, it's a dose escalation trial. So we begin with a very low dose of 15 milligram per kilo, and then we end with 100 milligram per kilo. So the first conclusion is that we can use the particle as a contrast agent, and we can enhance the contrast in the tumor. Here you can see the different metastases, and what we observe is that we have this highlight in the 4 types of cancer: melanoma, lung cancer, and colon cancer, breast cancer. The tumors are targeted by the EPR effect, and also by the fact that BHE is disrupted in the metastasis. Here you have the 3D imaging for each patient, and you can see that when we increase the dose, there is a higher contrast in the tumor. For example, patient 13 is the highest dose, and we can see that there is a good contrast in the different metastases. What we have observed then is that there is an increase of the contrast in function of the dose. Here you can see that when we increase the injected dose, we increase the contrast in the metastasis. And what we have also observed is that there is rather the same contrast for the different metastases. There is no difference issued from the primary cancer. Another important point is that there is an accumulation and a remnants in the tumor. What we can observe is that 8 days after the injection, there is still some signal in the tumor, and it's very important for fractionated treatment like the one we use here. Then there is some clinical response that we can discuss. It's only preliminary because there is only 15 patients, but there is a large number of metastases, so there is some statistical significance. And what we can observe here is that there is a better tumor evolution when we increase the dose. And for the last dose, for 100 milligram per kilo, there is good tumor evolution for the different metastases. What we can also observe here, we have correlated the MRI enhancement in the tumor and the tumor evolution. And what we can see is that when we observe a better signal in MRIs, there is a better evolution of the tumor. So the evolution of the tumor is directly correlated to the number of particles that are really in the tumor. here you have the clinical response for patient 13, and what we can see is that there is a large number of metastases at the beginning of the treatment, and 9 months after the treatment, there is only 2 metastases left. So to conclude on this clinical trial, for the moment we have 15 patients. The safety is excellent. We have no problem for each dose. There is a good tumor targeting, and so it's an answer to the question of the EPR effect in human. There is also persistence of tumor for more than 1 week. And the particle can be used as effective T1 contrast agent. And for the moment, the overall survival seems to be better than the classical survival for whole-body radiation therapy, but it has to be verified in the phase 2 trial. So to conclude, here you can see that the particle can be administered by intravenous injection. They are targeting the tumor by EPR effect, so enhanced permeability and retention effect. So then you can perform the imaging of the tumor to select the patient, or also to have a precise treatment contour. And then you can also activate the drug by the radiotherapy to enhance the effect of the radiotherapy. So the idea then is to perform different clinical trials with this particle. So here you can see that we have begun 2 other clinical trials on brain metastasis. The first one, Nanored 2, has begun last year, and for the moment 28 patients have been included. In this trial, we'll compare the particles with the standard treatment. In nanostereo, we'll use a stereotactic surgery to treat the patient. For the moment, 1 patient has been included. And we have also some trial on primary tumor. So the nanocall is on cervical cancer at Institut Gustave Roussy. And there is, for the moment, 6 patients that has been treated. And we will begin soon some treatment in the US for lung cancer and pancreatic cancer. And we have also funding for treating sarcoma here in Lyon. So then I want to thank all the people that worked on this subject, and especially Olivier Tillemans, that is a professor in my group, and also Dr. Xavier, that is principal investigator of the NanoRad clinical trial. And if you have some questions, do not hesitate.
Thank you for this very interesting talk, particularly about the clinical translation, really showing the effect in patients. There's actually a question from the audience, namely, is the retention of nanoparticle formulation of this gadolinium construct longer as compared to the gadolinium DOTA? And if yes, how long do they stay in the brain?
Yes, so from what we see in the tumor, there is a remanence for about 8 days, we have seen, and there is no retention in the LC tissue. We have not observed the particle in the LC tissue. For the blood circulation, we observe that the particle have a half-life of about 1 hour in the blood circulation.
So then the relative comparison, is it, I don't know, 2-fold higher as compared to the native?
Honestly, for the DOTA-REM, we observe that it goes very rapidly to the tumor, and then it departs very rapidly. So it departs in 30 minutes, not in 8 days.
Thank you then, Francois, for this talk. Let's move on to the next speaker, which is Georgia Pastorin, and she will talk about platinum complexes for treatment of all kinds of diseases.
Thank you very much, Dr. Cristianne. Thanks to the organizing committee for the opportunity really to present one of our recent work on drug delivery and targeting. And as I said, I will focus on platinum-based drugs. So historically, the development of platinum-based is based on drugs that have DNA damaging properties. With cisplatin, that is one of the prime examples. So this drug was discovered actually in the 50s, but still nowadays is used in clinical setting for many types of cancer. And the biological target is DNA, with which it forms inter and intra-strand, as you can see here. And basically this interferes with the division of cells by mitosis, and therefore cells enter apoptosis. Now, due to the fact that these drugs are extremely reactive and potent, it's not surprising that they have been used as first-line treatment for many types of cancer, including, for example, breast, ovarian, colorectal, testicular, and so on and so forth. However, this comes also with a hurdle, because being extremely reactive makes them interacting non-specifically also with the plasma proteins and other off-targets. And this is associated with side effects such as nephrotoxicity, ototoxicity, peripheral neuropathies, and so on. And this has brought us to think about ways in which we can decrease the side effects without minimizing or without decreasing the pharmacological activities. And therefore, we conceived a sort of tripartite approach, whereby we try to improve the drug to make it more strategically reactive. We try to improve the intracellular targeting, focusing on one organelle. And then we try also to increase the accumulation in vivo through nanomedicine. With respect to the first improvement, if you can see, cisplatin is a very reactive hydrophilic molecule. And basically, we convert it into a platinum-4 prodrug by including some functional group at the axial position. And this becomes an inert molecule. That means it does not interact with the biological target, and also is more lipophilic according to the functional group that you introduce. So we reason that this would have also facilitated the permeation through the cellular membrane and therefore the cellular uptake. But we also conceive a strategy to have a hydrophobicity reversal by converting this platinum-4 back into cisplatin through some reducing agents that are present in much higher concentration intracellularly than extracellularly. And this then can interact with the biological target. Now, in terms of intracellular targeting, we focus on mitochondria. And mitochondria are very interesting organelles because they are the powerhouse of a cell. They are in charge of ATP production, but they are also heavily involved in apoptosis. So they have this kind of dual role that is both vital as well as lethal. And these roles are impaired and dysregulated in case of pathological conditions. And in particular, in the case of cancer, you have that the neoplastic cells show really hallmarks of evasion from apoptosis. And this, they do that in two ways. One is indirectly by creating some repair mechanism of the damaged DNA, or directly by conferring insensitivity towards mitochondria, that becoming sensitive towards death signals. And therefore, we thought that if we target mitochondria also contain DNA, but differently from the nuclear DNA, the repair mechanisms are not very efficient. And therefore, we thought an effect or a targeting to the mitochondria might increase the pharmacological profile of our platinum species. So we had a library of compounds, and this is just one example that you have here at the top. Basically, your platinum-4 consists of a mitochondria targeting molecule. You have this TPP, and on the other side, we asymmetrically introduce the DCA. The DCA is a chemosensitizer, and unfortunately, it's not able by itself to enter the cell. But once it is incorporated in this platinum-4 prodrug, it's basically dragged inside. And when it is intracellularly reduced, this platinum-4 into platinum-2, you have the cisplatin that is liberated that can interact with the nucleus, the DNA, nuclear DNA, but also because of this TPP molecule is also going to the mitochondria. And this, in combination with the delivery of the DCA, enables cells to become, resensitize, and therefore be again sensitive towards the apoptosis signal. And in fact, we demonstrated that these complexes work through a p53 mediated caspase 3 dependent type of mechanism. I would like just you to focus on the last two scheme and graphs due to interest of time. If you look at the nuclear accumulation of the platinum species, and you have the cisplatin, oxaliplatin that are your reference, our most potent compounds were the 3-cis and 4-cis, 3 and 4-oxa. So I hope I'm back. Seems that Singapore is not welcome to this conference. Is the second interruption. Now I was telling you that in this case, our platinum compounds show a remarkable increase at the mitochondrial level. And this means that the activity at the nuclear side was not discarded, but actually was simply an increase of the mitochondrial effect. And there, the last effort that we did was to improve the accumulation in vivo through nanoformulation. And we conceive a very conventional liposomal preparation, whereby we basically utilize either thin film hydration or remote loading to load our platinum species. And therefore, we obtain particles with the good size and polydispersity and load efficiency according to the loading methods that we use. But basically, we obtain long circulating pegylated liposomes that then were used in preclinical models. This is a very simple colon carcinoma tumor model where we injected first CT26 cancer cell, and then we waited for the tumor to develop. And after about 15 days, we then injected the control, the vehicle, or even the chemosensitizer alone, or the cisplatin species, or the complexes, the platinum 4 complexes. And one sample included also the 3-cis, the complex inside the liposomal formulation. And we did an injection at day 10, 17, and 24. And we sacrificed the mice at 32 days. Now, if you look at the tumor volume over time, the control showed that it increased. Cisplatin worked quite well, but our complex at the half of the dose of platinum worked similar to cisplatin and much better when it was at the same basically concentration of platinum. And finally, if we consider the liposomal formulation, basically the tumor was not palpable after a few days. And in addition, what was interesting for us to observe was that when we look at the concentration in different organs of cisplatin and our complex, which by right reconstitute the cisplatin once it is reduced intracellularly, it was interesting to observe that there was not much of a difference across different organs and also at the tumor site, indicating that was not the amount of compound that reached the tumor, but rather it confirmed that it was intracellularly then having a different tracking and therefore targeting the mitochondria. And this resulted in a very different pharmacological profile. We also observed that there was a high concentration at the kidney, and we were a bit worried because we know that cisplatin is nephrotoxic. And indeed, even if we use subnephrotoxic concentration of cisplatin, we noticed that the expression of the markers of oxidative stress and inflammation associated with nephrotoxicity were all upregulated in the case of cisplatin, but not in the case of our complex or our complex inside the liposomes. And this tells us that with this tripartite approach, we could make our platinum species selectively reactive only when they were uptaken intracellularly. Secondly, by targeting the mitochondria, we could create an additional pharmacological effect, also in view of the co-delivery of a chemosensitizer. And this was further enhanced by packaging basically our platinum species into a nano formulation. So I would like to thank my bio-nanotechnology research group, some of our collaborators, the funding opportunities, and of course, all of you for your kind attention. Thank you.
Thank you, Georgia, for the talk. Despite being interrupted, it was an interesting approach to develop these, let's say, more structurally advanced platinum derivatives. So good luck in going forward. And due to the time, it's best to move to the next presenter, which is Matthias Wagner, who will give a presentation about nanoprimer.
Thanks, Cristianne, for the introduction, and I'll share my screen. And thanks to the organizer to give me the opportunity to introduce our company, Curadigm. Yeah, we'll put it on full screen. Okay. Yeah, just to introduce, Curadigm is a French biotech company, which has been created 1.5 years. We are a subsidiary of another French company, Nanobiotix. And what we are developing within Curadigm, it's a technology really to redefine the therapeutic balance between viability, toxicity, and efficacy for intravenously administered therapeutics. Why are we doing this? I think I should say that the last years, there was a lot of improvement in therapeutic technology, especially in nanomedicine. There is a lot of very relevant concept and product which has reached the market, but we are still facing some challenges. And one of them is really the liver trapping, which reduce viability of intravenously therapeutic agent. And what we want to do with Curadigm is to move from a situation where your therapeutic agent is quickly and massively trapped within the liver to a situation where it is less recognized, it circulates for longer time within the blood, and it's available for subsequent accumulation in the target tissue. How we do that? I mean, we design a concept which could be summarized in one sentence. It's really to prime the body to receive the treatment. What do I mean by priming? I mean, we design a nanoparticle, which is called the nano primer, which is a lipid-based nanoparticle, liposome, dedicated to be administered intravenously just before the therapeutic agent, and it will reach the liver and it will occupy the cells involved in the clearance of the therapeutic agent, mainly Kupffer cells and liver sinusoidal endothelial cells. Some advantages of this approach of our nano primer. I mean, since the nano primer is fully independent from the therapeutic, that means that you could combine this nano primer without modification of the therapeutic agent. So you can combine it with different therapeutic agents. The mechanism of action is based only on the physicochemical property and the composition of the nano primers. There is no API, no drug encapsulated inside, which can bring some additional toxicity on other healthy tissue. And from a practical point of view, it's quite easy to use. You just have to insert a first injection of this nano primer by intravenous route, something around 1 hour before the therapeutic agent. So the nano primer will reach the liver quite quickly, and it will occupy the cells involved in the clearance of your therapeutic agent. So when you administer 1 hour later the therapeutic agent, it will circulate and accumulate more efficiently within the target tissue. And since it's a lipid-based nanoprimer, it's biodegradable. So it's going to be biodegraded within the liver, and the liver will progressively come back to its physiological function and trap again therapeutic agent. So as I say, since a large panel of therapeutic agent, and more specifically nanomedicine, are cleared by the same pathway within the liver. That means, since we designed this nanoprimer to target this specific pathway of clearance, that means we could combine this nanoprimer with a large panel of product. I mean, on the nanomedicine encapsulating small molecule, nucleic acid-based technology, or genome editing technologies, such as CRISPR-Cas9 and so on, and some viruses such as AAV can really benefit of our approach. I mean, basically all the products which are massively cleared and or present in hepatotoxicity could benefit of this of our approach. So just to show you some result we generated on our concept, here, if this is the first proof of concept we performed in oncology. For this, we combined the nanoprimer to a liposome loaded with irinotecan, very similar to Onivide, the marketed product, and we performed a tumor growth delay experiment on mice model on HT29 tumor model. So here you've got the result on the left panel in terms in tumor growth delay. The red curve corresponds to the nanomedicine alone, the irinotecan loaded liposome, and the blue curve corresponds to the same dose of nanomedicine, but with the pretreatment with the nanoprimer. So as you can see, we significantly increase the efficacy of the treatment. Just to mention, the transparent red curve corresponds to the irinotecan loaded liposome, but with a dose increased to 1.5 fold compared to the opaque red curve. So you clearly see that we are in this range of 50% improvement of therapeutic efficacy when we combine the nanoprimer. And of course, we've got the same level of increase in terms of overall survival on the right panel for this animal. So this first proof of concept was made in oncology with small molecule loaded nanomedicine, but we are now more interested in another therapeutic family, which are the nucleic acid-based technology, because we really think this technology is very promising. I mean, there's a lot of companies, as you know, working in the field with a very promising product. Already some of them reaching the market, not with approval. But we also think that these products are still limited by liver clearance. So there is really something we can do to support the development of such product. And for this, we had the opportunity to develop a collaboration with the Langer Lab to evaluate the impact of our nanoprimer when combined with RNA-loaded nanomedicine, lipid-based nanomedicine. So what we've done during this collaboration is that we combine the nanoprimer with two different kind of RNA, silencing and messenger RNA loaded in nanomedicine. And we first checked what was the impact of the nanoprimer in terms of bioavailability of this therapeutic agent. On the left panel, you've got the impact of the nanoprimer on the liver clearance of this two kind of RNA. And what we obtain is that when we combine the nanoprimer, we are able to decrease by 40% accumulation of this nucleic acid within the liver. And this decrease of liver trapping is correlated with an increase of bioavailability of both RNA by 8-fold for silencing RNA and by 16-fold for messenger RNA. So we clearly improve the availability of our this nucleic acid-based therapeutic. But at the end, what we want to do is to increase efficacy of the treatment. So to evaluate this, we used for messenger RNA coding for human EPO, and on the left panel you can see that when we combine the nanoprimer, we are able to increase by 32% the production of EPO within the blood of the mice. And for silencing RNA, we targeted the factor 7 protein, which is expressed by hepatocyte, and by combining the nanoprimer, we are able to increase silencing efficiency of about 50%. So we are really able to increase efficacy of treatment of nucleic acid-based therapeutic agent with our nanoprimer. We recently published this result in Nanoletters with the Langer Lab. So now we perform this proof of concept on different family of therapeutic agent, and now we are seeking to develop the nanoprimer as a platform. So we entered in several collaboration with different partners to evaluate the nanoprimer on different nanomedicine, and especially in nucleic acid-based field, with a large panel of indication in oncology, rare disease, central nervous system delivery, and so on. And just to finish, to introduce the team, I just like to thank the scientific team which realize all this work, and all the people that support us, our advisory board of Patrick Tricoli and Jeff Rack, and Laurent Lévy, our CEO. And just to mention, we enter this year in a collaboration with the Nanotechnology Characterization Laboratory to perform the characterization of our nanoprimer. So thanks for your attention.
Thank you, Mathieu. Very interesting talk. Indeed, I heard about it, but the data looks very promising. I do have a question from the audience, namely, is the accumulation of nanoprimers in the liver by passive targeting? And the second question is, are you making these nanoprimers commercially available?
Thanks for the question. Accumulation within the liver, I mean, there is no specific targeting, I would say, on the surface of nanoprimer, but we define a specific composition with specific size, charge, also to be able to interact on the surface of macrophages, and especially with scavenger receptor and so on, really, yeah, to accumulate within the liver specifically. And it's on nanoprimer, is it commercially available? Not yet, but what we want to do is to develop this as a platform. So we can easily set up a collaboration to test the impact of the nanoprimer on the product of the partner. So if somebody is interested to make this kind of evaluation, we can discuss later on. Just contact me and we can let's see what we can do together.
Okay. Thanks, Mathieu. It was an anonymous question, so I don't know who asked the question, but probably will make themselves known to him or her, known to you.
Okay, thanks a lot.
Thank you then. Let's move to the before last speaker, which is Bert Müller from Maastricht in Switzerland, who will talk about nanomaterials and medicine more in general.
So thank you very much for the possibility to give here a talk. I thank also the organizers that I got more time than the others in the session. So I have 20 minutes. Thank you very much. And one of the reasons might be that we were successfully founded 2 companies last year in 2019 successfully. And both of these startup companies from my team work quite well, and also are related somehow to nanomedicine and nanostructures and nanotechnology and so forth. So therefore, I thank the organizers, and I will give you a kind of special talk today. So just to give you a kind of idea of what is behind. So everybody knows that usually we are dealing with structures that have a range from 1 nanometer to 100 nanometers. So that is in the range of bigger molecules. So that is the molecular range. But for sure, we are not interested in a single, let's say here, nanopyramids, for example, or single nanostructures, but we are rather interested in something that is maybe on the scale of millimeters or centimeters or even the entire human body. So therefore, we need many of these things and have to study it in an appropriate fashion. And this becomes clear, for example, for an implant. You see here a dental implant, and we can modify intentionally the biocompatibility, for example, by the surface morphology. So we can add some structures that are on the micrometer scale or on the nanometer scale, for example, by sandblasting, etching, and all the other things you know very well. For metals, it's quite arbitrary. For polymers, we know it now much better. But you get an idea how the stuff is done. And in my team, we want to go really down to the understanding of the physics and to the tailoring of nanotechnology. So therefore, this example is not a perfect one. And maybe one or the other had listened to my presentation on one of the previous CLINAM conferences. And what we are usually looking for is something we can find in nature. So why the surface of a bone implant has to be rough and has to show certain nanostructures. And that becomes very clear if you have a look to the bony tissues, and you will recognize that we have structures that are the hydroxyapatite crystallites, or that they are the collagen structures. And both I like to show you a little bit that it becomes very clear what it is good for. And I believe you will understand that mineralized particles are somehow related to a high degree of translational symmetry. And here I have to tell you why we are so close to surface sites. And the reason is simple, that if you have a cube, for example, for a nanometer with 3 times 3 times 3 atoms, then only 1 atom is in the bulk, and all the other atoms, the 26, are around our surface atoms. So 96% of such a nanoparticle would be surface, and just 4% would be bulk, and even that would be modified in a certain fashion. If we go, let's say, to a micron or so, then for sure it's much smaller, but still it's a very essential part. And we know that these particles are ingredients in toothpaste and sunscreens and so forth. And the key issue is the surface to volume ratio. So therefore, we can say surface science play a very important role, and that is something we deal with in my team and have dealt with in my team before. The high degree of translational symmetry we have, for example, also in hydroxyapatite crystallite is shown in this simple graph. And you see that if we look around, we see everything is the same. If we go to the next, everything is the same. But if we cut such a crystal, then we usually have its dangling bonds. And that is, from an energetics point of view, not very stable. So we need a rearrangement of atoms or an absorption of another species. And here you see what happens if you have a rearrangement, then you have a larger periodicity at the surface with respect to the bulk. So this means we can modify the properties of a surface with respect to the bulk. And one of the basic ideas was the structure on a silicon single crystal that is rather complex, because you see a 7x7 reconstructed surface with these atoms that can be visualized actually by scanning tunneling microscopy. And that demonstrates that the surface is conductive, because scanning tunneling microscopy only works on conductive surfaces. And if you have a single crystal of silicon, that is for sure a semiconductor, or if you have a titania, it is an insulator, but by some defects or the surface you make available, it becomes metallic. So it changes the properties due to the symmetry. And we tried our best to understand that even better, and therefore we switched from electrons to X-rays. Although electrons are much better because we have a much higher interaction between the species, so we can work with a higher specificity. But doing it with X-rays, we can investigate rather a volumetric range. And this is a paper we have published in Advanced Science some time ago with Anna Kimchenko as a first author. And we were able to see subcellular structures, so really nanoscales of the human brain and also mouse brain, but mainly human brain we were interested in. For sure, the size of the volume we could access was in the range of a cube millimeter max. So therefore, you see it is not so easy to visualize, let's say, the human brain on the nanometer scale. We are looking in my team now to have the best brain atlas worldwide, but we are looking for 1 micron pixel size, isotropic pixel size. And then we have already petabyte of data that is too huge to be investigated. And therefore, we have also used diffraction techniques or reciprocal space techniques as the small angle X-ray scattering. And on the right-hand side, you see the Precision Nanomedicine cover that is October 2020. And you see here what we visualized are the myelin sheets that have a periodicity of 17 nanometers, and that characterizes the orientation of the axons. And if you perform conventional histology, then you can see the abundance, but you cannot see the orientation of these nanostructures. Here you see the orientation of the axons related to the orientation according to that color wheel that within that kind of tissue that is human brain tissue. The same. This structure is very important for the function. You see here the role of a myelin that shows in Wikipedia movie simple that the conductivity of a signal is much better if you have these myelin sheets present. If they are not present, then you will not get the same result, and you have a disease present. So you see these nanostructures are essential for the function of our brain. Another thing that we have dealt with is dentistry, where we have demonstrated, and that I had shown already at the CLINAM meeting some time ago, the orientation of the nanostructures within here the dentin, where you see some carriers that can be repaired in a bio-inspired fashion if you use some orientation of structures, of nanostructures in that field. We can also use nanoparticles to remineralize the surface of the animal. we can use our technique also to characterize the orientation of the grains within nickel titanium, for example, and we can visualize their growth, for example, because of some phenomena. We know that the smaller grains are removed at the expense of the larger ones, and so we can tailor the grain size. That is also important to study the degradation kinetics of bone graft materials that have also some nanostructures. The first startup company we have built last year is Bot Medical, and the first product of them is the Natur Aligner. That is an aligner based on biopolymeric materials. So therefore, we do not produce these micro plastics when you have it in your oral cavity for, let's say, 23 hours a day. And for a period of 2 weeks and maybe for several times. So therefore, this is a very interesting product. And now we are looking for some additional financing. So if you have some interest in that green stuff, then please let me know. The same company is also now producing as an early investigation trainer for the tongue using some sensors based on dielectric elastomers transducers that we have developed in my team with different techniques, and that are they can use your tongue to press against these sensors and to train it, for example, to treat sleep apnea, or to look for anti-snoring as an anti-snoring device. And very recently, we have presented it at a MedTech Day here in Switzerland, and we were a winner from the Science Slam. So therefore, this is also a very promising idea, and that comes also from some basic research we have done and also published in the European Journal of Nanomedicine. The second company is Actera Therapeutics, and here I remember very well the presentation on the liposomes. But what we are doing is we produce very specific liposomes that are mechanically responsive or responses to other stimuli like ultrasound. And this is given, for example, within our own body. If you have an atherosclerotic vessel, then we have a constriction, and at the constriction, the shear forces are higher. We have also some forces related to the gradient pressure forces, and that can be used to release a drug like nitroglycerin from these 100 nanometer liposomes. And the company is now doing quite well. We are also looking for some money. So if you have any interest, then please let me know. And yeah, immunocompatibility had been studied as well. And you see Precision Nanomedicine had used the first cover of the first volume, our data. Finally, I would like to mention here nanoparticles, spions were mentioned as well, and we visualized them within zebrafish larvae. The spions came from the Alexio team from Erlangen, Germany, and the animals come from Jörg Huwiler's team, who is a pharmacologist or a technologist in pharmacology at our university, and we have done a lot of things with imaging that is related here to imaging using synchrotron radiation. And now we're pushing our developments towards the usage of our lab sources that is much better accessible to study zebrafish and make a series of experiments that help to support and to bring it towards human applications. And with that, I like to come to conclusions. So we know that materials with characteristic extensions between 1 and 100 nanometers will play an increasing role in medicine. Stimuli responsive liposomes will become an interesting vehicle to treat many diseases, including cardiovascular diseases, cancer, and so forth. Nanotechnology-based structures will be a key element in many medical devices. And multidimensional imaging, that means two-dimensional or even three-dimensional or four-dimensional imaging of the human body in health and disease is a target of current research, especially also in our team. Thank you very much.
Thank you, Bert, for a very interesting talk. And I know really also myself, the translation to companies and looking for money is part of the deal there. It's not only about science. Let me see if there's any question from the audience. I do not see any question. And I would then say, because of the times and probably because of maybe some stomachs that will start making noises, let's go to the last speaker, which is Dr. Silke Kroll from Italy, from Bari, who will talk about complex 3D structures.
Perhaps I go in what you mentioned already before. Sometimes it's not enough just to do science. Sometimes it leads even to small companies, and my one is also an example of that. So I will talk about, let's say, 3D structures, but I have to make a disclaimer because we filed a patent for a commercial purpose regarding the use of the introduced structures as cell growth substrate. So at the moment, we are at the position that current medicine goes in the direction one treatment fits all, with, let's say, the already mentioned limitations. I will not introduce this into much detail, but we are all agreeing on the fact that future medicine will be personalized medicine. And I think we will never be at the point that every patient gets his own drug, but he will perhaps get his own mixture of drugs. And so what we still need is fast therapeutic decision-making and individualized treatments. How to achieve personalized medicine, for example, in cancer. There is the possibility to gain access to the patient's tumor tissue. Then when I grow this tumor tissue in a very short time, I can have a model which is mimicking better perhaps the reality of the patient's complexity of the tumor tissue. And if then I try with a mixture of approved drugs in individualized concentrations, perhaps we are going one step further in direction of personalized medicine. The existing models, which at the moment are serving as a test bed for, let's say, drug response, especially in rare tumors, are 2D cell culture and some organoid cell cultures like floating 3D and embedded 3D culture in hydrogels. And then a more complex system, more advanced system is usually xenografts of patient's tissue in immune deficient mice. All of them have some limitations. The cell culture, I think we can all agree on, is the basic model, but it's scarcely realistic. The floating 3D is a little bit difficult to handle. Embedded 3D culture to get reasonable spheroid sizes is time consuming. And also the xenografts in immune deficient mice is time consuming, and it's against, let's say, the triple R, in which we want to reduce the number of animal experiments. So what I would like to introduce is a new platform. It's an inorganic material, and we are able to grow different types of fractals in increasing complexity and in different orientations, as you could see in this image. And what we did was we were starting with some primary tumor cells, growing them on these different surfaces. And here you can see the results of cancer-associated fibroblasts seeded on isolated extracted from a tumor, from a hepatocarcinoma of a patient, and seeded on the surface of this fractal structures I have shown you before. And as you could see that with increasing complexity, we are going more and more to very complex, very active fibroblasts, but let's say they are still into culture on flat surfaces. We usually also observe 2D culture, but as you could see in image B, we also get some kind of 3D structure. So we were interested what exactly could be this. And we went into more detail. We did different stainings. So in order to confirm that it's, if it's aggregates of fibroblasts, we did staining with alpha-SMA. But as you could see, we have alpha-SMA very homogeneous and very distinctively distributed in the 2D cell layer. So this for sure are cancer-associated fibroblasts. But what we observe is that we have a very, let's say, limited signal of alpha-SMA in the 3D structure. And in this case, we found that we have a strong staining for alpha-fetoprotein. So it looks like that the small amount of contaminating tumor cells from the isolation of the cuffs were accumulating and were forming immediately, more or less, small microtumors on the surface and attached to the cell layer of cancer-associated fibroblasts. As you could see, this 3D structures of microtumors are forming more or less immediately. So this is on day one, sorry. And in the next image, you see that they are growing in size, but they are still present even on day 6. The other images I have shown you were on day 13. Then we did the same experiments on the different structures with cancer cell lines, and we compared the size and, let's say, the growth of this spheroids or organoids. No, in this case, spheroids. For example, in the traditional matrigel cell culture. And we found that, let's say, in matrigel on day 13, we get, let's say, approximately 100 micron tumors. And we found already on day 4, with the same cells, micro tumors or microspheres of the size of 74, let's say, microns. So they are much faster. They are forming more, as I said, more or less immediately, and then they grow in size. We did the same experiment also with CACO2 cells, and as you could see that they also, those are forming, let's say, spheroids. And on day 8, in this case, we found, let's say, a micro tumor size of 150 micron. And as always, we have in the case of the fractal structures, a mixture of attached and freestanding microspheres. So they are attached to the surface, they are not floating, but on the other hand, they are also exposed to the solution, which will facilitate the experimental setup. We tested human adipose stem cells, and here you see in the corner on plastic, then on the different generations, and also here, as you could see, we are forming spheroids. This is on day 1, and here you see, let's say, a comparison and the staining, because we thought that this 3D structures, at least on day 8, looks like neurons and neurospheres, and we were doing a staining for nestin, which is an indicator of neuronal stem cells, and with NOI-N, which is an indicator for mature neurons. And as you could see here, we have a blue signal for DAPI, so there is a very low expression profile of NOI-N, but there is already some green of nesting. In the lower image at day 8, you can see that more or less all the nuclei appear violet, which is due to the overlap of the signal of NOI-N and DAPI, but you still see also some nesting expression on the spheroids, and especially in the 2D. So it looks like that the surfaces are, without any additional factor, are able to induce differentiation into neurospheres and neurons. And this is the team who performed the experiments. It was the collaborative work with the University of Twente, with Arturo and Niels and Erwin, who were providing and inventing, let's say, the fractal surfaces. Our team was responsible for the biological experiments, and also Simona. And fractal surfaces will be on sale from, let's say, December this year on, and on this website. Thank you for your attention.
Thanks, Silke, for an interesting talk, and particularly also seeing the, let's say, the commercial exploitation via this company. So it's an exciting journey. I do not have a question from the audience, but I had a question myself, namely that there seems to be quite a large size differentiation, or size distribution, I should say, because of the high standard deviation. Is that on purpose, or can you, is the aim to further narrow that in the future, and can you monitor and control that?
I think if we can interfere with or influence it by the number of deposited cells. So, but on the other hand, as you could see in the example of the Matrigel, also in Matrigel, you have a large size distribution of this microtumors. So we can influence it. We can have, let's say, bigger spheres when we are seeding more cells, more tumor cells.
Okay, well, thank you. Unless there is any further question, then I would like to thank all the speakers of this session. As said in the beginning, really quite diverse, from the more regulatory to the more commercial exploitation, to clinical application, and so on. So really interesting. Thanks a lot. And wish you bon appetit with the lunch, and thereafter a successful follow-up session.